Thank you very much. My name is Paul Ryfors. I am the CEO of Episurf Medical. So this is the first time we are presenting at an ABG event, so we're happy to be here. Let's get to it. We're dealing with osteoarthritis, and that's one of the bigger healthcare challenges out there. Highly problematic for individuals who are affected, and it imposes a lot of costs on the society each year. And Episurf is targeting unmet medical needs in primarily two interesting segments. The knee segment, which is the largest one within orthopedics, and also the ankle segment, which is among the fastest growing ones. And if you look at osteoarthritis, the development often starts in a younger age, maybe in your mid-20s. So you get a hole in the cartilage, in this case, the knee. Year after year, that becomes bigger, and ultimately you're down to bone on bone, and that's extremely painful. And at this point in time, you have more or less fully developed osteoarthritis. And younger patients, they're treated with biological procedures. That doesn't really work above about 35 years of age. And older patients are treated with knee replacement, but that's something that's not recommended for younger patients between maybe above 65 maybe. So in between here, there is a well-established treatment gap of middle-aged patients. And in this treatment gap, we are driving the development of small implants and the establishment of this as a standard. These patients, they are in pain, and this is problematic in the daily life. They are often in the middle of the life. They should be starting a family, making a career, etc. So this is problematic, and you measure this primarily on a KOOS scale, knee injury osteoarthritis outcome score. And we will follow patients in a large European multi-center study, and these are the pre-operative values that we will see on those patients, on pain, symptom, etc., etc. And what you see here is the minimal important change you need to achieve, and the red line and the dotted line indicates what the FDA requires from us in our US study. And the endpoint is often a knee replacement, as you can see, and this is a big procedure, and this is what it can look like with an Episurf implant in your knee. A knee replacement, that's a big procedure, and they have a limited lifetime, so you often need to change them once, and that's complex surgery. And up to about 20% are not satisfied, so it's not a safe way out in any way. And when it comes to the slightly younger patients, and maybe in the mid-50s or so, the results are variable. And it's also very clear that when a patient presents with only a partial thickness cartilage lesion, the results and reoperation rates are worse. So it's quite intuitive to look at a mini metal implant and figure out that you change a damaged part of your joint with an implant, but this comes with significant clinical and technical challenges. One is the surrounding and opposing cartilage. What happens with that? So imagine having a slightly tilted metal implant. It will create osteoarthritis, wear and tear on the opposing cartilage. You need to understand the bone quality. This is extremely important because the pain sits in the bone. You don't have any pain in the cartilage. And also the access and positioning, just look at the ankle on your right here. How do you get that implant in there in the first place, and how do you get access to the defect site? So Episurf has developed a technology that's based on MRI images and also CT scans for the ankle. So based on that, we analyze not only the cartilage lesion, but also the underlying subchondral bone lesion. And based on that, we design a patient-specific implant and patient-specific drill guides. And as you will see, this is necessary. And these then replicates the unique anatomy of each individual patient. And in the operating room, at the bottom here, you see, for example, how our patient-specific osteotomy guides assist in the osteotomy, which is extremely complex to do on freehand surgery. And at the top, you see when we're drilling the hole, we're changing the interval of 0.2 millimeters in each step. So it's extremely precise, and it has to be. There's no alternative. The implant is coated with hydroxyapatite and titanium, so it grows into bone, and it's a one-piece metal implant out of cobalt chromium, so it doesn't break down, and that's a well-known prosthesis material. This works well. The implant sits very well there, as you will see now. So we are up and above 1,000 implantations with this implant now. And the clinical history and the regulatory history looks like this, that we had a CE mark 7-8 years ago for the knee family. We had the CE mark for the ankle implant just last year, and last year we also started a trial in the United States targeting an FDA approval. But interestingly enough, one of our a new product we have developed, we can actually aim at the 510K product. So we are aiming at submitting that later this year. And the preclinical work in Episurf is substantial, and we had 5 publications out there, but even more importantly, the clinical publications came out really last year. We had the big volumes, and we are also expecting a number of publications this year. So we are now in a totally different position scientifically than what we have been historically. And what does the results say then? So these were the patients, again, repeating the same group, and you see that the clinical improvements are significant. And if you look at survival data for various procedures, meaning that how many months and years does it take until the procedure must be redone, you see many metal implants, standardized one that has been tried, biologics, all of those fail of 20-50% after 5 years. And the Episurf implant, we have a 97% survival rate of actually up to 7 years in a published study. So we're standing out there. And can we also bring clinical improvements after 5 years? And we have early data, so I will be upfront with the fact that this is a smaller cohort of a larger study. But we have seen that the 5 data just looks excellent. And as we saw also in a Swedish study with 10 patients, a smaller one, we had strong improvements up to 24 months. And the preliminary data of the 5-year follow-up shows that the strong results at 24 months actually last at 5 years and actually up to 75 months on average in this follow-up. So it does work. As the rehabilitation is also strong, it makes a good and compelling package here with up to about a year rehabilitation before you can engage in any light sport or so for biological procedures. From full range of motion up to light sports, you have about 8 weeks for the Episurf implant. So again, very strong. The last graph on this section is the first patient we treated with the ankle implant. It's about 5 years now, but we have 3-year data on this patient. And he has a perfect ankle. We did this one during the product development phase. So the clinical scores are just excellent. The improvements are very strong. And this is a predictable results for a wide age group, given that we have the pre-surgical tools you just saw. Rehabilitation is fast, and the implant survival rates are higher than any other alternative treatments. So what's next then is a couple of publications this year focusing on health economics, functionality, and so on. And we're also then looking forward to more data on the mid to long term, 5 years and upwards. So we have about a 10-year history, and we are now ready to target a market. Our market segment is worth an estimated $1 billion. And we are aiming at a 30% market share long term, and 3 years after FDA approval, we're targeting a 15% market share. And within orthopedics, the knee segment is the single largest segment, accounting for just about $9 billion of revenues annually. And there is a steady growth driven by demographic factors. You have obesity and increasing average age, etc. So more knees will be needed over time. And in the extremity segment, new technologies enable new treatments. So there's significant growth in the extremity segment where we have our ankle implant. And if you look at our customer group, that is the orthopedic surgeon. So about a third of the orthopedic surgeons out there are focusing on the knee, which again is the biggest segment, and about 10% on the ankle. So if we look at all of our target markets and make some analysis out of that, we think that somewhere between 20 and 30,000 orthopedic surgeons are our target market, really. So if we look at our $1 billion segment, we arrive at that figure by looking at the big demographic trends, of course, and 2 million knee replacements in our markets. We look at the science. What does it say? How many patients present with a certain type of lesion that we can treat? And importantly, we look at our experience. How many patients do our surgeons see every year, et cetera, et cetera. So in addition to all of that, we are also, of course, reviewing new applications for our technology, and we have an interesting pipeline we're reviewing, and the criteria include, of course, a shorter time to market and a relatively easy regulatory pathway. So how we are going out in the world with this technology, first of all, you need to secure that you have a strong support from key opinion leaders globally, and we have that second to none, I would say. And we have either a distributor or sales reps in a number of countries, as you can see here. And we also have regulatory clearance, or we are working towards regulatory clearance in a number of markets globally. Some markets are more tricky. It takes a bit longer time. The US market is an obvious example. But it feels good then that we have built an IP portfolio globally again. Over many years, we continue to file new patents, covering everything from the software side of things to surgical tools and implants. So we have some time to execute on our strategy as we necessarily will have. So if you look at the market, about 60% relates to the US market. But let's focus for a minute on Germany, which is a $100 million opportunity for us. And today we're small and we are early, but we have a 0.5% market share in that market. And what we're doing in Germany, so we have about 2,000 relevant knee surgeons in the German market. And we're only actively sort of working with 30 customers if you look at the last 12 months. But what we are seeing is that our customers are using the implant with the frequency that we expect. So the big group average is 7, but that group is, of course, that figure is diluted by new surgeons coming in. But our established users are using this about 15, sometimes more times a year. And just last week, we had our biggest event by far ever. And we had over 370 orthopedic surgeons dialing in for a webinar with 2 strong German key opinion leaders. And the surgery you see on your right-hand side here is actually from Charité in Berlin, where we had another surgeon visiting, learning about the Episurf, now going home to do more surgeries at home. Also an important type of marketing. So we are running quite fast in Germany, I would say. But again, I would admit that we are early. So the surgeon journey, this is a Belgian surgeon. He is high up in the international society. He's a well-established global key opinion leader, invited to all big clinical studies. And he's been using the Episealer for many years, but only really in his most difficult cases. But now, when we have the clinical data, as you saw, he has entered into a new phase. And you see he's now trending at actually 20 surgeries a year. And this is a guy who often prefers biological treatment. So we have now entered into a new phase with the data, and we can market more actively, and surgeons are much more prepared to market this technology as it now is evidence-based. So what would it take then to go from 0.5% up to the first 10% market share in the German market? So let's look at it. And it's pure math, so it's quite simple, but let's illustrate it anyway. You have an annual run rate today, I said, of about 7, but the established users are where they should be at about 15. And our customer group today, less than 50. But surgeons we have in our prospect list and who we are in dialogue with, several hundreds. So we need to, of course, then go from a customer group of less than 50 up to somewhere above 200 with a run rate of north of 10 implants. Then we're starting to see a meaningful market share in the German market. And I repeat that is a $100 million opportunity alone. And the strategy for doing this is essentially based on clinical data. That's where it all starts. Without that, we're nothing. Reimbursement, second important step, and then global establishment. We saw that we have an ambitious global strategy. And we need to constantly make sure that our technology is the best one out there for these focal lesions. And pre-FDA approval, I will focus on the first bullet here. We want to deliver substantial revenue growth, high double-digit growth rates. Then again, more focus on getting market access, etc. But that's the financial commitment before an FDA approval. But after FDA approval, we are targeting a long-term market share of about 30% and 15% 3 years after FDA approval. More short-term milestones. This year already expecting 3 more publications, important ones, especially, or actually all of them are important. We are expecting a bigger publication on a 5-year data from the large European group sometime early next year. And second half of next year, we're expecting the first results from an ongoing TALUS study. We are also committed to communicate results from the US study sometime second half of next year. That group will be smaller than what we anticipated. COVID has created a delay, but nevertheless, we are committed to communicate where we are at that point in time. And our 510K product, we are aiming at filing that this year with the sales start and launch in the US market next year. 2 other important things include the reimbursement project in the UK. So UK is more or less a non-existing market for us today. Reimbursement is the key there. We're working with that early next year. I expect to communicate something. And the strategy for the US market for ankle implant is also something that we are focusing on developing at the moment. And more long-term, I would say that the most important thing is to look out for the clinical results in the EPIC knee study, which is the US study. FDA approval expected somewhere 24-25 for the big knee family. And also investors should look out for a strategic decision on how to commercialize the full portfolio in the US market. But we have all of those interesting milestones ahead of us. But meanwhile, we are actually commercializing as well. And we had a strong growth in the number of customers in the first quarter. We had more than a doubling of the number of countries we're active in. And the gross order intake amounted to 2.1 million. So we had a nice growth. But remember that all of this has been achieved during what is probably the most difficult and challenging times for elective surgery ever. And we had just short of 140 million in the bank at the end of the quarter. Looking at the shareholder list, that includes 3 of the Swedish AP funds. Niles Noblet is the co-founder of Biomet, which is the global market leader in orthopedics. Strand, Lehman Partners, etc. So we are very proud of the shareholder list we have. And if you look at the board of directors, Dennis Stripe has about 40 years of experience from the industry, predominantly from Stryker. He's the chairman, and most recent additions include Ulf Grunander and Annette Brudin Rampe, and Ulf Grunander, for example, 23 years as CEO of the Getinge Group. At the bottom, you see Professor Leifrud. He is the orthopedic surgeon who founded Episurf about 10 years ago. So with that, I will round this off and invite a few questions. Thank you very much.
All right, Paul, thank you very much for that presentation. Moving into Q&A. Could you comment on how Episealer compares to competitive alternatives such as Hemicap, Unicap, Biopoly, and CartiHeal?
Sure. So I think the interesting thing is not actually the actual implant, but it more relates to the positioning and the pre-surgical tools, etc. It's an extreme pressure on those joints, especially the knee joint. You have up to maybe 5-6 times the body weight every time you're walking a stair or something. So the implant must be positioned exactly and slightly recessed to the surrounding cartilage. And this has been tested in animal studies and so on. And our pre-surgical analysis and our surgical tools enables just that. So we have the right implant for the right indication. And these other standardized implants, they have significantly higher failure rates than the Episealer, and we attribute a great portion of that to the pre-surgical analysis and the tools. And the final comment on this is actually that is needed. So in our world, there's no patient-specific specificity is not a nice to have in this case. It's crucial and it's needed.
Sure. And looking more specifically at CartiHeal, they rather recently announced the study data from 86 patients showing a revision rate of 9.3%. Can you talk a bit more about those results, what they mean, and how Episealer compares to that data?
Yeah, of course. So first of all, CardiHeal, the patient group is about 10 years younger on average than us, so it's slightly more tilted towards biology. I think the term is synthetic plug, really, for that kind of implants. And there's been many attempts historically, and many of them, or more than all of them, removed from the market. So that is tricky. They have been very good with their study in the United States. They started with a strategy that focused 100% on a IDE trial, and they're finished up the recruitment. And these results you're referring to, we saw that was actually the first publication we saw from a European group. So the revision rate is significantly higher than the Episurf, and also if you read they had about 40% adverse events, so there was something wrong. They had to go in the knee again and so on. Our comparable figure was maybe 5%, and we had a 2.5% revision rate in our large European study. So that's a big difference. And then it's a very different technology than ours. But when we saw those results, we feel comfortable that we have something that's very strong and works very well in the hands of really any surgeon.
Sure. And you touched upon it in your presentation a bit, but it would be very, very helpful if you could sort of summarize Episurf's path toward a potential PMA approval in the US. What are the FDA's requirements? How are you designing the study, and how has your historical results compared to their thresholds, etc.? Would be very helpful.
Yeah, sure. So I didn't have a single slide on that specifically, but it's a randomized controlled trial. So we have 180 patients, 2-to-1 randomized, and the control arm is microfracture, which is commonly used, but doubtful, we think, biological procedure. You drill small holes to stimulate regrowth from bone and upwards. So it's a 2-year follow-up, and we need to show non-inferiority to microfracture, but superiority in weight bearing. All the sites are recruited. We have the opportunity to add more sites. We have 50% of the sites in the US and 50% in Europe. So many years have gone into this preparation, and the first patients are treated. But COVID has, of course, created a very difficult situation. And we have 5 sites in the UK, for example, and research activities have not been allowed in the UK. So it's been a tough year, definitely. But we have come a long way, and looking at the endpoints that the FDA requires from us, for example, then a 10-point improvement in KOO scores, we have done that many times over in Europe. So, and also when it comes to implant migration, etc., from those kind of things, we have reason to be comfortable because we have delivered that on very tough cases in Europe historically. So we feel good about the trial. We feel good about the endpoints. The big challenge is to properly get it started now and see an uptick in patient recruitment following COVID improvements.
Sure. And the timeline there, do you have anything communicated? So
we've expected about a year for patient recruitment and 2-year follow-up, so 3 years until submission. So that would lead us to somewhere 24-25 until a PMA approval can be obtained.
Absolutely. That's very helpful. And just a final one from my side here. Can you talk about the potential in the foot segment and how it compares to the opportunity for the knee implants?
Sure. So the knee segment, to start with that, I mentioned it's the biggest one in orthopedics. It's extremely prestigious. The burden of proof is high and big. So in the ankle, there are a fewer number of alternatives, and our short experience now is that these lesions are actually easier to find. In the knee, there are other things that can be in question, the meniscus, for example, and so on. In the ankle, when they have this kind of lesion, it's often suitable for an Episurf, we've seen. Technical challenge to get access, you saw in the video. And a smaller market, but potentially a faster one to penetrate. And these patients often end up with fusion or a big ankle prosthesis that doesn't work. So it's a product that's in demand as well.
And it's typically the same end users there as well?
Sometimes we have customers who do both knees and ankle, but they are many of them are focused on knee and ankle, but they are often next door to each other and so on. So getting access and being accepted at a hospital for one of the products helps us tremendously to market the other products.
Sure. Right, that's all for me, and in the interest of time we will have to end the presentation here, but thank you so much again, Paul, for the presentation. Looking forward to keeping in touch and hopefully seeing you here next year as well. So thank you very much for participating.
Thank you. Thank you.